Hello, this is Dr. Eric Bricker, and thank you for watching A Healthcare Z. Today's topic is a roadmap to a high-performance employee health plan. That's right, today I am going to lay out the grand unifying strategy for how a high-performance health plan can be assembled, in my opinion. And if you stay till the end for the punchline, I will tell you that this is not in theory, that this has already been done, and it was done over 12 years ago. So, let's get into what this looks like. So, what we have here is a pyramid, where we have acute care, specialist care, and primary care here on the bottom. So, the foundation of the high-performance employee health plan is primary care. No surprise, all of you know that. Now, it's not just primary care. It has two key components. First component is the location of the primary care. It has two locations. It has a virtual location and it has an in-person location. So the point is that in this day and age, really the in-person visits and the virtual visits, they really need to be fluid so that you can meet employees where they are and you can meet a geographically dispersed employee population. So the primary care comes in the form of both virtual primary care and in the form of an on-site near-site clinic. Now, that's the first part of it. The second part of the primary care is that it is a patient-centered medical home. It is a third-generation patient-centered medical home. It is a third-generation patient-centered medical home a la Dr. Brent James from Intermountain, who has already created this and already proven that it works. And by third generation, it means it has care management, most often with nurses for chronic diseases such as your COPD and your diabetes. It has mental health services, depression, anxiety, etc., whether it be through social workers or counselors, etc., psychologists, psychiatrists as well. Third piece, and then it has health system navigation. The health system itself is so complicated, which is what we did at Compass, that you actually need a person whose full-time job is just to navigate the person through the complexity of the healthcare system itself. Okay, so that is your primary care piece. Now, the way you pay for that primary care piece is not through your health insurance plan, and in other words, it's not through your TPA, it's not through claims, it's not through your ASO, it's direct. You directly contract with these folks. Now, the other key to here is that the physicians and the nurses, all the providers here, because we're not doing claims, they're on salary. Because the number one thing that makes this foundation of primary care work is love. And you've heard me say this before. And love is spelled Time. In order to do appropriate primary care, it needs time. And when you put the practitioners on salary, they then take the time needed, the half hour, 45 minutes, hour-long visits to do effective primary care. Okay, so here's your foundation, primary care, which also allows you then to control the steerage and the referrals into the specialist care. So obviously primary care physicians are not going to be able to take care of everything. Of course you're going to need cardiologists and gastroenterologists and ENTs and OBGYNs. They're wonderful doctors. Of course we need them. We need them as the next layer on top of the foundation of primary care. Now, this is where the existing, or not the existing, just a TPA or ASO with a large national network, because of course you're not going to directly contract with all the different specialists out there. That's impossible. This is the traditional claims-based network relationship adjudication that you have today, that you know very well. There's a major difference though, and that is that there is plan design that allows for steerage to the highest quality specialist and away from the lowest quality specialist within that PPO network. There is steerage within the PPO network baked into the plan design, such that the highest quality specialists have very low to even no out-of-pocket costs for the members, whereas the poor quality specialists have higher out-of-pocket cost for the members. So there is a direct financial incentive through the adjudication and the plan design to get the patients to the highest quality specialists. And then finally, the top layer, because of course, seeing the gastroenterologist or the cardiologist can't fix everything, of course you're gonna need acute care hospitalizations. You're still going to need to have major surgeries, etc. Of course, horrible things happen that require orthopedic surgeries, like, such horrible degenerative joint disease that you gotta have major spine surgery or you gotta have a knee replacement. The horrible reality of cancer. You have primary care, you have specialist care, people are still going to get cancer. You have cardiovascular disease, people still needing coronary artery bypass grafts, etc., or aortic valve replacements. Here is going to be, again, it is a direct care sandwich. Here you're going to have direct contracts through centers of excellence for orthopedic care, cancer, and cardiovascular care. Or centers of value, they may also be called as well. So this doesn't necessarily have to run through your carrier either, right? So you got sort of a carrier sandwich, right? Where you're going to have your TPA ASO here in the middle, but you're going to have direct contracting here on the bottom for your primary care, and then you're going to have direct contracting for your acute care hospitalizations on top. And of course, not all hospitalizations, like, your labor and delivery, that might, because you can't do that with all the different OBGYNs all over America for deliveries. So maybe your deliveries don't go through that way. But the point is that for these major diagnostic categories that are drivers of high cost claims of ortho, cancer, and cardiovascular, you can do direct contracting. So there's your pyramid. Now, what I did not put on here is this is all then surrounded by a transparent pass-through PBM. I'll say that again. All of this is surrounded by a transparent pass-through PBM. And the great news is that there are more and more options to do that. Now, this all makes sense if you're self-funded. If you're fully insured, you can't do this. Your number one step, if you're fully insured, is to go self-funded. And until you go self-funded, there's not really much of a conversation for us to have. Essentially, if you have more than 150 to 200 employees, you should be self-funded. There are very few reasons why you would not want to be self-funded. So just, for all those folks out there that are around 150, 200 employees and you're fully insured, you need to give some serious thought. Because to a certain extent, it's almost like employee benefits malpractice to be fully insured and not self-funded. So, but if you already are self-funded, then this is what the roadmap looks like. Now, here's the punchline part. This has already been done. This is not some sort of Eric Bricker theory. This, as you already probably know, has already been built and accomplished and implemented over 12 years ago by John Torrance, the CEO of Ceregraph, where he put in place this model. And what he did required a $2 million upfront investment for his company of 1,000 employees based in Wisconsin. They make dashboards for cars and trucks that they are then a supplier to GM and Ford, etc. Now, as a result of this, they were able to then save $31 million over the next 9 years. Their health plan costs remain flat. And so if you compare, after they put in that $2 million, they put in this. They kept their healthcare costs flat for 9 years. So then if you compare the difference between what their healthcare costs were versus the rise in the healthcare costs, and you add that up over the 9 years, they saved $31 million, right? So they didn't spend $2 million a year. They spent $2 million extra once, and it yielded them $31 million. So there's a 15-to-1 ROI. But that for 1,000 employees, $2 million up front, is they had to make a $2,000 per employee upfront investment. So just know that if you've got 500 employees or 2,000 employees or 10,000 employees, that for every 1,000 employees, if you're going to do what John Torrance did, you're going to need to spend $2,000 per employee to at least match from a budgetary perspective what he did. But it yielded a 15-to-1 ROI. Now, at the end of the 9 years, and oh, by the way, he wrote all this in the book, The Company That Solved Healthcare, which is copyrighted 2010. This thing was published 12 years ago. And to this day, the majority of the people that I talk to who work in employee benefits have still not read this book. It's like this thick. the print is really big. It's like super easy to get through. Now, his per member per year, not per employee, per member per year cost was $3,640, which is like half the national average. It's like less than half the national average. Now, another Wisconsin employer, QuadMed, they really heavily focused on this bottom primary care piece, and they focused on it so much that they actually got their annual per member per year cost down to $3,135 per member per year. Even better than Serigraph. So, the key to both the John Torres Serigraph story and the QuadMed story, and John Torres says this himself in the book, is the key is that this roadmap was spearheaded by the CEO. I would argue I don't know if there's an HR department in America that can go to their CFO and just be like, hey, I need $2,000 per employee just as an upfront investment for our benefits. Like, I'm not sure that's really an ask that any HR person could do. But that is a budgetary allocation that the CEO could do. And in fact, he or she probably would need to have a serious discussion at the board level in regard to that. So same thing at QuadMed. It was the CEO of QuadMed that made this happen. So really, the roadmap to a high-performance employee health plan really starts with the CEO. And I would even argue that unless you have the CEO spearheading this, like not just like on board, not just bought in, but unless you have the CEO spearheading this, I'm not sure you can do it. In fact, one of the sort of grandfathers in the wellness space, this guy D. Eddington, you may have heard of him, so he's out of Michigan. And one of his rules for his wellness company is that he required a 30-minute one-on-one meeting with the CEO of a prospective client. Otherwise, he wouldn't even want to work with him. He said, unless the CEO is willing to take the time to spend 30 minutes with me to talk about the health of the employees, well then, they're not going to be a good fit. And guess what he found? The majority of CEOs would not spend 30 minutes with him to talk about it. So, I'm not saying that this is easy. It takes time, it takes money, it takes commitment, it takes the CEO. But the point is, it can be done. It has been done. And I make all these different videos, but I wanted to tie it together here so you could see what that roadmap would look like. And that's my point for today. Thank you for watching A Healthcare Z.